Hello, my name is Dr. Mark Alberts, and this is another Medscape Neurology update for stroke. So what I wanted to talk about over the next 2 to 3 minutes was the results of a very important stroke study that was presented at the World Stroke Congress and published in the New England Journal of Medicine several days ago in September. This is the ECASS 3 study. This study was designed to test the safety and efficacy of intravenous TPA given 3 to 4.5 hours after the onset of an acute ischemic stroke. So basically what this study attempted to do was to see if IV TPA was safe and effective given beyond the 3-hour time window, which is the typical time window to give it to patients with acute ischemic stroke. The maximum time threshold was up to 4.5 hours. Now, the study protocol was very similar to the typical IV TPA protocol with a few important exceptions. Number one, patients with a prior history of stroke and diabetes, so stroke combined with diabetes. If you had that in your prior history, you were excluded. Patients with very significant strokes, as defined by an NIH stroke scale score of greater than 25, were excluded. And patients with early ischemic changes on the head CT in greater than a third of the MCA territory were also excluded. So with that as a background, what did the study show? Well, 821 patients were enrolled. Half got TPA at the typical dose, 0.9 milligrams per kilogram with a maximum dose of 90 milligrams, and half got placebo. The primary endpoint was a modified Rankin of 0 or 1 at 90 days. So this was a positive study. There was a statistically significant 7% absolute increase in the number of patients treated with TPA in the 3 to 4.5 hour time window who had the endpoint of a modified Rankin of 0 to 1 compared to placebo. And the p-value was statistically significant. For other outcomes such as Barthel and a global outcome score, the results generally were in the same direction. Now, what about bleeding complications? Well, this is one of the challenges in this study because symptomatic hemorrhage was defined using a European definition. And using that definition, the rate of symptomatic hemorrhage was 2.4% with TPA and 0.2% with placebo. Obviously much greater with TPA. Now what's interesting is that in the paper they also looked at the definition of a symptomatic hemorrhage that was used in the original NINDS study. And there the rate of symptomatic hemorrhage was 8%, which is sort of consistent with the 5 or 6% range that we see when using TPA within 3 hours. So at the end of the day, what does this mean? Should we be changing our TPA protocols now to treat people up to 4.5 hours? The answer is really unclear at this point. The ECASS study was a large, well-done study, but it is just one study. Prior studies trying to extend the time window beyond 3 hours have largely been negative or inconclusive. On the other hand, a pooled analysis of many of these studies did show some efficacy out to about 4.5 hours, which is consistent with what we found with ECASS 3. So at this point, we're waiting for several national bodies such as the American Academy of Neurology and the American Heart Association to see if they're going to revise the guidelines. We're also waiting to see if Genentech, which makes TPA, is going to go to the FDA and ask for a label change approving the use of TPA out to 4.5 hours. At this point, I would continue using the 3-hour protocol, talk to your colleagues, see what these national organizations are doing, and see what the FDA decides to do, if anything. Thank you very much for listening to this Medscape Stroke Update.